Welcome to another episode of ThinkBox Radio, a podcast inspired by Sears ThinkBox, the innovation center at Case Western Reserve University. Our goal is to share some of the magic that happens at the Case School of Engineering and to inspire your own innovations and startups. ThinkBox Radio is produced by Abby Murphy and is sponsored by the Case Alumni Association. Now, let's meet our host, Robert Smith, the former economic development reporter for the Cleveland Plain Dealer.
Hello, everybody, and welcome to another episode of ThinkBox Radio, the podcast that illuminates some of the research and innovation going on at the Case School of Engineering. We're here today with Anirban Sen Gupta. He's a biomedical engineer and the Leonard Case Professor at the Case School of Engineering. Anirban is a researcher working at the intersection of material science and biomedical engineering. He's on a quest to create artificial blood. And I know that sounds a little gory, but let me tell you two things. One, he's pretty close to success. And two, if he succeeds, it's going to be a game changer for healthcare. So Anirban, welcome to the show.
Thank you. Pleasure. Thank you for the opportunity.
So let's get right to it. Why do we need artificial blood? Why is that important?
Great question. Blood transfusion is a clinical mainstay in a variety of scenarios where people either are at a bleeding risk or they are bleeding out. So we can think of scenarios like surgery. We can think of scenarios like somebody has some genetic disorder that is rendering them to bleed. We can think of scenarios of healthy people but getting into accidents or getting into casualty scenarios like gunshot wounds or stabs. And we can obviously think of the military or warfighters who can get injured in the field. So across all of these scenarios, heavy bleeding is an issue. And the way to treat heavy bleeding usually is by blood transfusion.
That means putting blood in
them. That means putting blood in them. And the only source of the blood or blood products to put in these patients is blood donation. So if you think of American Red Cross, they are doing blood drives all the time.
Sure.
You might have seen, drive trucks around, which means we are heavily donor dependent in getting the blood or blood products that we need to transfuse. Never, ever, there is a parity or a match between the demand and the supply because we never have enough donors.
We never have enough blood.
Yeah, enough donors, right?
Enough donor.
The donation drive only probably meets about 40-50% at best of what we need.
Where do we get the rest of it?
We can't. That's the problem, right? And then you get scenarios like the COVID-19 pandemic, when for 2 years there were no blood donation drives.
Yeah.
But that doesn't mean that blood transfusion was not needed in those 2 years. So it was even worse. And there were national emergencies declared a couple times about unavailability of blood products. So that's the biggest need that this artificial blood surrogate or whole blood surrogate is what we are calling it, that we are trying to address. That can you make something that is biosynthetic but behaves as close as possible to real blood, but is donor independent, can be stored for long periods of times, and then can be given to patients on demand without facing the challenge of do you have a donor or do you have a blood bank close by? That's
interesting. Pausing on the shortage of real blood for a moment, and we did a great story on you about 3 years ago.
Yeah.
And we said you were going to do big things, and you are. And you pointed out then that oftentimes bleeding to death is considered a preventable death. We just didn't get blood to the people in time.
Right.
So what's the problem with blood is blood, and that's a problem, right? It doesn't travel well. It doesn't keep.
Yeah, it doesn't travel well. It doesn't keep. There are time limits on when you can transfuse them into a patient. And obviously, availability, as I was saying before, continues to be a problem. When somebody needs blood, it doesn't really follow a program that, okay, there is blood available and now somebody needs blood. It can happen anytime, especially if it's in an emergency situation, civilian accidents, mass casualty scenarios, battlefield injuries, etc. The need for blood can happen all of a sudden, number one, and number two, the average time of death from bleeding out is less than 2 hours. So it's about 1.6 hours. So there is no guarantee that the patient who is bleeding out has access to blood transfusion in under 2 hours. And that's the need where could you take something that is like blood in the ambulance or in the helicopter or in the first responder system to the patient, whether it's civilian or soldier, and treat the patient as soon as possible following the bleeding injury. And that improves the survival probability. So that's a big deal.
And why is that? What will the artificial blood be like that you can do that you can carry it onto the battlefield and have it in the ambulance? And what would this stuff be like?
Sure. So if we think of what our natural blood does, it's a very complex fluid. But if we boil it down to three fundamental things that a natural blood does is it helps carry oxygen to our tissues because it has red blood cells in it.
I remember that from grade school.
Right. And it helps form necessary clots to stop bleeding.
The platelets.
The platelets do that. And it has plasma, which contains coagulation factors that help in the clotting, the necessary clotting. But plasma also is the medium through which platelets and red blood cells flow to the rest of the body. And plasma maintains the body temperature and the blood pressure. So there is a flow system, there is an oxygen carrying system, and then there is a necessary clotting system. If we boil it down to those three functions and create three synthetic scenarios where each of those scenarios are performing those functions, then the integrated product of those three scenarios could be considered serving the purpose of a natural blood system. And that's what this artificial blood would be. It would be actually a freeze-dried powder. That's the vision.
Like a tang or something? Add water and
add water. Yeah, it would be exactly like that. And the reason for that is multifold. You can store it for longer periods of times as a freeze-dried powder without the need for cold chain. Liquid blood products require cold chain to be stored. Cold chain is not always available in many countries and in the battlefield.
Sure.
The other is the portability. If you had to carry liquid and gallons of it, that's a big challenge for carrying it in the ambulance or in the helicopter or on a medic. But if you had powder, which has small carry weight, small volume, and a couple bags of sterile saline, all you could do is mix it up as needed, on demand, where it's needed. And we often call it point of injury or point of care application rather than waiting for the patient to come to the hospital. The treatment is going to the patient.
Sure.
So that's sort of the vision of the project.
Okay. Well, we could certainly see the military interest in this. And something happened recently. I'm going to use a big academic name here. The Defense Advanced Research Projects Agency, better known on campus as DARPA. Everybody loves DARPA funding. And they gave you and your team of collaborators a big grant, $46 million now, to launch a new project that is going to maybe take you over the goal line and create this artificial blood. So tell us about this project that you're about to embark on.
Absolutely. So creating an artificial blood is a very complex ask because on one hand, you have to create something that matches as close as possible the biological functions of natural blood, as I was talking about, the oxygen carrying, the necessary clotting, the blood pressure, the flow.
Mimicking biology, I think.
Mimicking biology, yeah. So biomimicry itself is a very complex ask because what we have as natural blood has happened because of thousands of years of natural evolution. So trying to recapitulate that in a artificial system in itself is a very challenging scenario. But on top of that, it's not just the science, but also the logistics that needs to be resolved. For example, what if in a liquid form, the systems work great, but if we freeze dry it, somehow we lose some function?
Sure.
What if we don't lose some function when you're freeze drying it in small amounts, but when you scale it up to pounds and kilograms, somehow the function is lost partially. So all of these possibilities can happen.
Mm-hmm.
So what DARPA is asking this multi-institutional and multi-partner endeavor to do is not only solve the science, but also solve the logistics of scale up, storage, portability, operational availability in the battlefield, and potential operational availability in the civilian sector.
They want you to create a product that works.
They want us to create a product that works. They want us to create a product that can save soldier lives,
Okay.
and then potentially can get adapted in the civilian scenarios.
Okay, interesting. They want practical application.
Right.
Sure.
Right. So this is why it seems like a very complex ask, and it is a complex ask, but it is tranched into various modules that will all run in parallel, looking at the biological part, the scientific part, the logistics part, and the tactical part.
Okay.
All in parallel, ending hopefully in about a 4 years time period.
Oh, the clock is ticking.
Into this product.
All right. Are you pretty far along in the science? Do you feel confident?
The individual components are pretty far along in science, but the components have never been put together in this framework.
Yeah, and tested.
Right. So our collaborators in University of Maryland, who is leading actually the DARPA program, they have been working on an artificial red blood cell system. We have been working on an artificial platelet system, and there's a company that's working on the plasma.
That's your specialty, as I recall, the artificial platelets,
yep.
which you've already developed.
Yeah. So that's what I mean, that individually, the components are pretty far along.
Okay.
Right? But we have never had a chance to put them together and see, does one interfere with the other? Or maybe even better, does one boost the other?
And
it can
we
go
should
either
add
way.
your third collaborator. Is that University of Pittsburgh?
No, so the University of Pittsburgh is actually in charge of the animal models and the blood bank. So because we have to compare it with real blood,
Okay.
the military currently uses stored human blood. And the average time of storage is about 26 to 30 days in the fridge. So what we need to essentially test is, does our product work as good, if not better, but as good as the stored human blood? So we need a blood banking component.
Yeah.
And so the University of Pittsburgh is doing the blood banking, but we also are doing a few animal studies to make sure that, anatomically, the system works in bleeding models in animals.
Okay.
And the University of Pittsburgh and University of Maryland and the University of San Diego have different components of the animal model where this product is going to be tested.
Okay.
So they're doing a few things across different
All right, well,
universities.
you certainly have a working model. You have to match then real blood.
Yeah. Yep. So the DARPA requirement, as per the program, is that by the 4th year, we should be at least 90%, if not more, close in function to natural blood, while not compromising the scale up, the storage, the portability, all these other logistical and tactical components. So that's why all the modules are running are envisioned to run in parallel.
Okay. So I think I'm getting the idea, but so this has been called an historic effort, a world first innovation.
Mm-hmm.
Why would they call it that? Is it just because there's never been artificial blood, or this kind of collaboration to create it?
Yeah, it's a bit of both. So the context of artificial blood, if we use that terminology loosely, actually started during the AIDS epidemic in the 1980s, because people were very afraid of donated blood, because that was one source of getting HIV.
Yes.
But what people mostly researched at that time are essentially artificial red blood cells, not as much artificial platelets or freeze-dried plasma. So they were relying heavily on the oxygen-carrying property of the blood, and the rest of the blood components were kind of on the back burner from a research standpoint. So there have never been attempts to integrate all functions together in a single system. So that's why it's first in the world, because it has never been tried.
Okay.
The other big aspect is because of the complexity of the problem.
Yeah.
Although there have been investments from the pharmaceutical industry and from the federal government through NIH and DoD in bits and pieces of moving this research along, this kind of a big investment where it enables people to move all the pieces in parallel in 4 years have also not happened.
Yeah.
So both from an investment and vision standpoint, as well as from a experimentation and operational standpoint, it is really first in the world. There are no
Okay.
prior reports of putting all the components together into a single system. to see what
Okay.
happens.
And the $46 million grant, is that the biggest you've ever attracted?
Well, the grant is not just mine.
Right, the whole
The
team.
grant is the whole
But that
team.
you're a part of.
Yeah, that I'm a part of. But yeah, so again, I do not know obviously the financials of DARPA, but what I have been made aware of, that this is being funded through the Biological Technology Office of DARPA, which deals with, as it says, the bio stuff. And within the BTO office, I have been told that this is one of the largest grants they have ever made.
Bravo.
Thank you. Yeah, this is exciting.
Yes.
So it has a lot of moving pieces, but altogether, this kind of effort has never happened before. Which
I'm
is super
assuming
exciting.
you know a lot of these folks and have worked with them, the blood scientists.
Right.
There can't be that many.
Right. Yeah, I have, and that's how I know that while we have been collaborating for, I would say, at least last 10 years,
Okay.
we have only had partial funding to move the needle a bit further, but not
Okay.
like really move the needle.
Okay.
And this DARPA funding now enables us to really push the envelope and try to get to the point
Okay.
of a fully artificial blood system, hopefully in 4 years.
Is that so? I was going to ask, in 4 years, what do you think you have? And that's the big goal.
That's the goal.
Okay.
Yeah. So the exciting part is that just like our technologies have been licensed to Hyma Therapeutics, which is a company I co-founded about 6 years ago.
And they're the ones that make the platelets?
They are the ones that make the platelets. So just like, some of our technologies are licensed to Hyma, some of the artificial red blood cell technologies from Maryland are licensed to a company called Kalocyte, K-A-L-O-C-Y-T-E. And the freeze-dried plasma is also being developed by a company called Teleflex. And so there are industrial partners involved in this endeavor, which makes the endeavor very translational. This is beyond academic research, right? This actually goes into doing the things that are needed to get a product to a patient. And that's why this is a very unique team, because it involves scientists from universities and then business folks from companies working together in creating something that could be successful in 4 years. So it's a very unique endeavor.
The platelets that you patented, are those being used?
Not in humans. We have done several different animal models
Okay.
where they have shown success. So that's what I mean, that they are
So clinical studies.
clinical studies have not happened.
Oh, these animal studies.
Animal
sorry.
studies is called preclinical.
Okay.
So preclinical studies have happened in a variety of animal models with very successful data. So that's why we know that we have something that works.
Okay.
Now, whether it works in a human, obviously would require clinical studies.
Yes.
And the goal of this DARPA project is to get to the point where we can take the information to the FDA and request. It's something called investigational new drug application, or IND application.
Okay.
And so if FDA approves an IND, then we can go into clinical trials. So the clinical trials earliest of the whole system, the individual components might get into clinical trials earlier, but the clinical trials of the whole integrated system is at least 4 years, if not a few years more away.
Okay, sure. I mean, you're putting this in the human body. It has to work. I think it's interesting this is seen as an engineering project. Or is it? Is it a material science play? What would you say?
Well, it's a very interdisciplinary project, because if we think of how, again, I'm going to go back to the example of how our natural blood works, right? It is a biological substance, but its functions are very systems engineering. is what I would call it.
Sure you would.
Right.
Okay.
Because if you think of oxygen transport, which is what blood does,
Yeah.
it falls under the category of gas exchange,
Yes.
which is a chemical engineering problem.
Yeah, no,
right?
I love how engineers can claim anything that's a system.
Well, it is a system, but it's a very complex system, right? So it falls under this big thematic area of gas exchange, which or mass transfer and gas transfer, which are engineering problems. Blood is a flowing system.
Oh.
So the moment you think of a flowing system, there is fluid dynamics.
Sure.
There is shear forces.
Oh my.
There is turbulence. All sorts of stuff that are
No.
engineering aspects.
It's your field.
Yep.
Oh yeah.
And then if you think of clotting involves about 14 different enzymatic reactions happening almost simultaneously, one helping the other.
Oh my.
Sometimes.
Chemical engineering.
Yeah. So that's again a kind of a materials engineering, chemical engineering
Yes.
interface problem.
Okay.
So if we think of the functional outcomes
Yeah.
of what we are trying to achieve, the functional outcomes are engineering outcomes,
Yeah.
but we are trying to modulate biology to get engineering outcomes.
Yes.
So that's why it's sort of a highly interdisciplinary project, and across the team, including us,
Yeah.
there are clinicians, engineers, obviously, material scientists, business development people, graphic designers, manufacturing people, because they want to scale this up.
Okay.
Then what we call operational expertise, which means, okay, if we are successful in making this, what is the last end product that a soldier medic is getting in their hand? Is it a tube? Is it a syringe? Is it something pre-made? Is it a sterile bag of powder? Because we have to consider from an operations standpoint, many of these applications, at least in the battlefield, will happen maybe in the dark, maybe under fire, maybe in a
Sure.
hostile environment. So you have to kind of consider where it's going to be used
Yeah.
as the end product, or how an end user will want this.
Yeah.
So the example that I always give oftentimes, and it's a fascinating invention, is the EpiPen, right? Using the EpiPen, which is for treating allergy or shock from allergy.
Yeah.
The whole thing comes in a user-friendly system where you just jam it
Yes.
in your leg and deploy the drug right away,
Yes.
which means it's a very rapid deployment framework, right?
Yes.
You want to get that kind of a scenario, not an EpiPen, but I am just using that as an example.
No, it's a great example. In fact, it's a case alumnus, Arun Varshnaya, who
Yep.
invented the glass
Yep.
that's unbreakable
Right.
and makes it work.
Right. So that's the kind of thing that's on the operational end of stuff. So all these moving pieces are involved in this endeavor. But the unique part is it's not sequential, it's all parallel,
Yeah.
right? So every module is driving towards a success
I know.
metric
Yeah,
in
you guys are on
parallel,
a
so that at
blitz
the
here.
end they can all converge.
Well, that's
into the
exciting.
system.
I can see you're jazzed for it, and I can understand why.
Yeah, I'm super excited about it because, as is evident from that write-up in 2018 in the Alumni magazine, we have been yearning for this bigger vision project for quite some time, because some of the folks that are involved in this project, we have already been collaborating for the last 10 years, but not at this scale. So for 10 years, we have talked about this, like, oh, wouldn't it be great to do something like this? And here we are at last, embarking on that journey.
All right. Awesome.
And it makes it even better coming back to this from the gloom and doom of COVID. And I would highlight that, because I think, operationally, morally, mentally, physically, and COVID is still going on in certain extent, right? But the shutdowns, for the right reasons, they were shut down, but it really impacted research outcomes,
Well, I bet. Yeah.
and productivity and all this kind of stuff.
Yeah.
So, that dip that we had there,
Yeah.
coming back from that and riding on this trajectory makes it even more exciting.
Oh, I'll bet. So, Anirban, I want to switch gears here,
Sure.
and I'm kind of curious. I want to talk a little bit how you got started down this road. So, you came from Calcutta
Mm-hmm.
to get advanced degrees at University of Akron,
Mm-hmm.
polymer engineering.
Chemical engineering,
Ah.
but with polymer concentration.
Okay,
Yeah.
you joined CASE as a researcher about 10 years ago.
About in 2003, so
Okay.
a long time ago, 20 years.
So, how did you get started into blood science?
Yeah, very, very, I would say, convoluted pathway, but very exciting pathway. As an international student who graduated very close to 9/11, the industry opportunities were very limited. I did not really foresee that, okay, I'm going to be a faculty or I'm going to be in industry. I was kind of, I could do one or the either depending upon opportunity, and hadn't really thought through the independent faculty position as a researcher, academic researcher in a university. But in 2003, after doing some industry experiences at Procter & Gamble, and before that in a company called Guilford Pharmaceuticals in Baltimore, these were industry internships. I came back to academia, and after interviewing at a few universities, I really liked Case Western for three reasons. One is I wanted to do something in research that I have never done before. So I have never worked with blood ever in my entire life before coming to Case Western.
Okay.
My PhD is not in the blood space.
Well, you're in it in a big way now.
Yeah, well, it worked out, I guess, to a certain extent. So that was number one. And Case was, and it's still, a university where it had, within walking distance, multiple medical institutions.
Yeah, that must be helpful.
And that was very exciting to me, with the thought, I still didn't know I was going to do blood stuff, but with the thought that, okay, I would be able to learn and talk about real world problems because I could walk into any of these buildings and meet a bunch of clinicians.
Cleveland Clinic.
Cleveland Clinic,
University
Case School of
hospitals.
Medicine, university hospitals, the VA hospital, they are all walking distance,
Yeah.
right? So that was super exciting. And then the third thing was the person that I interviewed with, Professor Roger Marchand, who passed away about 6-7 years ago.
He was a legend here.
Yeah, so he was a biomaterials professor here at Case, but Roger also never trained in heavy biology until he came to Case. He was a polymer engineer, so he came from a very materials engineering, chemical engineering, polymer engineering background like me. And then he did his PhD with Professor Jim Anderson at Case School of Medicine, where he learned his bio-relevant aspects. And he met his wife, actually, Professor Candace Marchand,
Yes.
also who was doing her PhD in Professor Jim Anderson's lab.
She runs that fantastic cheese shop on Coventry.
I know, but
Cleveland
before that, she had been the chair of pathology at Cleveland Clinic for a long time.
The first woman to chair an
right.
institute at
Right,
Cleveland Clinic.
Right. So through learning all of these, I found an environment where it is almost by default interdisciplinary, right? So there were, people going across schools doing things, which I found super interesting. So I joined Roger's laboratory as a research associate, which is a designation for postdoctoral researcher. And he, at that time, was pursuing a project where he wanted to make a polymer coating for devices that contact blood and fail because blood clots in the devices. So he was trying to make a clot preventing or clot reducing polymer coating for devices such as the ECMO machine or a vascular graft or a hernia mesh, something like that. I got involved in that project from a materials engineering, polymer engineering standpoint, because the goal was to make a polymer-based coating for these devices. But in the process of making those coatings, I obviously had to start learning about, how does blood clot?
Yeah.
right? So that was my introduction
Yeah.
into the blood biology. And then while Roger pursued this coating project and I stayed involved in it, I also started looking at what do other people do in the blood research field, just to expand my knowledge, right? And very quickly I found out that there is a lot of interesting reports dating back, as I was saying, since the 1980s and then up till 2003, 2004, when I had just joined CASE, of trying to influence, the word that I was used is influence or modulate clotting biology positively or negatively. And what I mean by that is there are patients who cannot clot, and then there are patients who unnecessarily overclot. So there is that spectrum where you need clot making or clot breaking, while Roger is working on clot preventing. So in my mind, there was the systems engineering that, okay, if I take clotting as my system, can I make dials to prevent, make, break using artificial or synthetic material systems? That was the broadest idea that I started doing my own independent research with. And I wrote a grant on the very first generation of artificial platelets to the American Heart Association back in 2006, which fortunately got funded. And with that funding, I started my own independent research lab as a tenure-track faculty.
Okay, so they gave you the initial launch to the Heart Association.
Right, yeah.
Interesting.
Right, and then obviously, the next was NIH grants, and then by that time, the design had, or one of the designs, which I think the cartoon is actually right here, it had gotten refined to the point of a product, so to say. And so in 2016, we launched the company, because by that time, some of these have been patented.
And if folks are listening on the radio, he's pointing to a drawing on his whiteboard. Can you explain what this is?
Sure. So what you see over here are so the SP. If you see a circle or a disc-looking thing which says SP in the center, the SP stands for synthetic platelet. So
okay, it looks like a yellow lifesaver.
Yeah, it looks like a yellow disc. And what it essentially is a nanoparticle that is decorated on the surface with a variety of colorful things, if you can see the board. And all of those colorful things are peptides or biological motifs with very specific binding functions. And beside the yellow synthetic platelet, I've actually shown how a real platelet works. So the platelets are shown in sort of these red crisscrossed.
These red little spider webs.
Yeah, spider webby spaces. So those are cells that are platelets that are responsible for forming a clot to prevent bleeding. And the way they form the clot essentially is by integrating a few functions called sticking, clustering, coagulation, and secretion. So these 4 gears. So again, going back to Bob's question about how does an engineer think of biology, we can think of platelet as a 4-gear machine or a stick-shift car where each gear is giving you a different function. One is speed, one is torque, things like that.
Yeah.
So some of those functions allow platelets to rapidly stick to where the bleeding injury is. Some other functions allow platelets to rapidly cluster with each other to form a plug that can start stopping the bleeding. And then some of the functions allows a protein called fibrin, which is like a mortar that deposits on platelets to secure the plug so that the clot doesn't pop off and re-bleed under the pressure of the blood. So what we have done on the nanoparticle is look at these kinds of motif-based functions of platelets and mimic them with little peptide molecules so that we are recapitulating all those modular 4-gear functions of platelets on a fully synthetic system. So that's what essentially one of our artificial platelet designs are. But then you can basically expand on that by loading other things within the particle that can get released where they are working to get extra functions.
Fascinating.
Or loading things in the shell instead of the middle. in the yellow crisscrossed part.
So this is a design of an artificial platelet.
This is the design.
Now, I took a picture of this. Is this proprietary?
No,
Okay.
we have published it. You can.
Good.
This is already patented. So yeah.
Fascinating. So Anirban, you started here as a researcher. Now you have your own lab.
Right.
Tell us about your lab. I assume it's been growing. Who's helping you do this work?
This is fantastic. So our lab, I still remember I started my lab with 2 master's students and 1 undergraduate student. And now we have 6 PhD students, 4 postdoc students, and probably about 6 to 8 undergraduates. So it has grown tremendously over the years. And about 5 or 6 people have already graduated with their PhD from the lab, and 3 postdocs have actually moved on to do, one of them is a teacher in Jamaica and the other 2 are in the industry. Now, one of the postdocs who is in the industry, one of those industry is actually our company, Hyma Therapeutics.
Oh, yes.
And the VP, the vice president of the company, actually had joined my lab as an undergraduate back in, 2010.
Yeah.
Her name is Krista Poloski.
Yeah, she got her PhD here,
Yep,
right?
she did get her PhD from my lab.
Awesome.
So she did her undergrad 2 years in my lab, did amazing. And then she got her PhD in my lab and published 13 papers in, 4.5 years. She's a superstar. And then as she graduated, when we discussed, and this is a discussion I have with all my students, like, what do you want to do next and how can I help with it? So at that time, we already had patents on some of these artificial platelet technologies. And Krista said, how about starting a company? And I'm like, how about it? Let's do it. And that's how the company got started in 2016. So the lab has grown tremendously. The exciting part in the lab is, since I would say 90% of our research is still in the blood space, but they are not all artificial platelets, but we do various different things. Like I said, there are some clot breaking research. There are certain research on heart attack and stroke. There are certain research on developing diagnostic devices to look at clotting functions or clotting dysfunctions. So because of all of these different connections to the blood field, again, going back to the systems engineering standpoint, considering blood as a system, probably 10 or 12 projects have spawned with the thematics of doing blood research. And that helps the team become very dynamic because different people can overlap or interact across different projects so that the output of each project is a very team output and not one person output. And this is why we have been very productive all through. Last year.
Oh, that's great.
Yeah. So, if you think of, again, the downtrend of productivity during COVID, which was 2020, 2021, last year in 2022, we came back and published 14 papers in 1 year. And that is only possible because it's not 14 people individually working on 14 papers. There are 20 people in my lab, but in groups of different projects, they are all helping and interfacing with each other so that somebody is a lead author on one paper and a co-author on a different paper. We have a lot of undergraduates that have become even first author in some of the publications.
Nice.
Majority of these undergraduates joined our lab, whatever year they joined. They usually join in fall and they get trained through fall and then start doing their experiments in spring. And they use their experiments to write the source proposal. And then, many of them get funding through source. So they continue their research with source funding in summer. So by the end of the summer, they are operating as independent researchers doing their own projects or teaming up with other people. And this gives them the opportunity to make big impacts in giving conference presentations and publishing peer-reviewed papers.
That sounds like just what you want to be as a lab.
Yeah. It's I love my lab. Nobody works in a silo and they're very dynamic. They're
so I know you guys have a lot more work to do. We're going to be watching you.
Sure.
And congratulations so far.
Thank you.
hopefully we'll be back in 2 years or 4 years, and you're going to show us.
Absolutely. Hopefully,
the
we'll get
artificial blood.
other interesting things that are happening in parallel to this DARPA endeavor to talk about soon. Because
Yes.
some of the diagnostics research that we are doing in collaboration with Dr. Pedro Mohseni and Dr. Umad Gurkan, buildings next door, so mechanical engineering and electrical engineering, they are panning out to be really interesting point of care devices, because in our mind, we are working on therapeutics to treat people, but you need diagnostic devices to tell us who to treat with what. Without that knowledge, it becomes a one-size-fits-all treatment that might not be helpful. So we are in parallel with these collaborations. We are developing diagnostics systems that will tell us, okay, who needs just platelets versus who needs the whole blood, or who needs maybe just plasma alone. And
They're on our list, those professors you mentioned.
Yeah, that's great.
Podcast down the road.
That is
All
great.
right, I think that's going to wrap it up for today.
Absolutely.
Thanks, everybody.
Thank you.
This was
Appreciate
another
it.
episode of ThinkBox Radio from Case Western Reserve University, where our motto is, think beyond the possible.
And making blood is beyond possible, but we'll make it possible.
Very good. Well done.
Thank you.
And that concludes another episode of ThinkBox Radio, stories inspired by America's leading college innovation center. Thanks for listening. You can find past episodes on our website, casealumni.org. Goodbye from Case Western Reserve University, where our motto is, think beyond the possible.